Hello and welcome everyone. Good morning or good afternoon depending on where you're coming and joining us from. Welcome to this COVID-19 coffee chat on continuity of care for residents in permanent supportive housing during isolation and quarantine. I am Elena Boyer, Director of Research for the National Healthcare for the Homeless Council in Nashville, Tennessee. I will move now to the HRSA disclaimer, and while that is up and while you guys might be reviewing that because it's so exciting, I'm just going to explain a little more background and why we're here today and why we're all together. So as you know, people experiencing homelessness, healthcare, and housing providers and the HCH community have grappled with the stress, grief, and disruption and uncertainty of the COVID-19 pandemic. There are serious challenges and barriers to providing continued care in the shelter-in-place environment. Service providers are bringing their skills, creativity, and empathy to support their clients and tenants when facing isolation and quarantine. So we'll explore some of those ways they are doing this during this coffee chat. Our format for today's hour is a coffee chat. We call them coffee chats because they are informal conversations, so we invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for us all to share ideas, challenges, and support one another. We hope you'll engage throughout. One of the best parts of the coffee chat is getting to hear from people doing similar work all over the country and experts like you. So we ask that you join and participate by using the chat feature here. We'd love to hear your questions, comments, solutions, thoughts, ideas. So please be active and participate as much as you'd like using the chat. And so today's panelists come to us from the Corporation for Supportive Housing, also known as CSH, which is also a national training and technical assistance organization providing expertise on housing services, HUD-TA, and continuums of care. We also have with us today two representatives from the local housing organization Park Center here in Nashville, who provides housing services to our most vulnerable folks. And lastly, we have a director of behavioral health joining us today from the Orlando Healthcare for the Homeless Health Center, a part of the larger Orange Blossom Family Health Centers. So again, some instructions on how to engage with us during the chat today. We want to hear from you, as I indicated, and welcome your questions and stories throughout the chat. We'd like for you to engage, as I mentioned, using the chat pod. And you can see the attendee chat pod here to the right of the screen. Also, your comments will show up to all participants, and I will refer comments and questions to the panelists as they come in. First up, let's see who we have in the room today. We're going to be posting a poll question to see who you are and where you're joining us from. So, Brandon, if you can post the poll, that would be great. And you can enter your responses just on the screen and click so we can get an idea of who's with us. So I'll allow for a few seconds of that. Great. They're still coming in. This is great. So far, okay, it looks like a majority are joining us from continuums of care or homeless service providers. That's great. We do have a good quarter of joining us from the Healthcare for the Homeless program, so that's wonderful. Great. I'm glad you guys are joining us. Give it a few more seconds here. It looks like the majority of those joining us are from housing sector, so that's great and that's so wonderful. So we're really looking forward to hearing from you guys and looking forward to you participating. So thank you for responding to that poll. So thank you so much. So great. Before I introduce today's panelists, I wanted to point you out to the COVID resources link, resources pod. That is also on the screen to the bottom of the slide. So there's some great resources there. You can see some of our upcoming coffee chats that will be happening May 15th and on the 19th as well. So please make sure you look into those opportunities to join us as well. We have some council resources that have been really great. So please take a look at those. And we have two great resources from the Corporation for Supportive Housing on how to advocate for your clients and other guidelines that might be helpful during this time. So at this point, now I'm very happy to say a warm welcome to our panelists today. And I will have each of them introduce themselves and tell us a little bit about the work that they do and their organization, and maybe a brief description of how they're adjusting to the current environment. So we'll just go down the list. Julie Nelson, do you want to start?
Sure. Thanks so much for having me today, and I'm happy to talk to everybody and kind of learn from everyone as well. So my name's Julie Nelson. I'm with CSH, Corporation for Supportive Housing, and as mentioned, we're a national not-for-profit. We're a CDFI, and we do training, technical assistance, and policy work all connected to supportive housing. For those of you who aren't familiar, we don't actually have a portfolio of units, so we kind of work on the other end of things. I am a part of the Illinois team, so I office out of Chicago, Illinois, and I focus primarily on our health and housing initiatives. And really, for all of my healthcare for the homeless folks, housing is healthcare. You know, we all know this and see it every day. I come from a supportive housing provider previously, then I worked for the Chicago Healthcare for the Homeless provider. I spent a little time in managed care, and now I'm with CSH. So I hope everyone is doing well.
Great. Thank you, Julie. David?
Thanks, Elena. I appreciate it. Good afternoon, everyone, or it's afternoon where I am in Nashville. It's great to be here in such good company. I see a lot of names that I recognize, and I'm just grateful for the opportunity to share a little bit about what we do at Park Center. I've been with Park Center now for about 3.5 years. We serve people in the Nashville-Davidson County area, people with mental illness and co-occurring disorders. And we have a number of programs that I can tell you about a little bit later, but I just wanted to mention that we do 2 levels of supported housing, neither of which would meet HUD's definition of permanent supportive housing, but there are several overlaps that I think would be interesting to people who are doing kind of a traditional PSH program. One, we serve people in 18 properties. In on-site services, we visit at least twice a month to provide support for people to maintain their housing. And so it's sort of a scattered site, units that we all own. And then the other program is a little bit higher level of support that we call our supported program. So that one is 24/7 in-home care provided at 2 locations with 8 people in each home. And so that program is reimbursed by Medicaid or TennCare. And the purpose of that program is to really help make sure that people are able to stay out of a psychiatric hospital and transition back into mainstream housing in the community. So that's just a little bit about our housing programs. But like I said, I'll speak a little more specifically about what we do at Park Center in a little bit.
Great. Thank you so much, David. Danielle?
Hello. I'm in Nashville as well, and as David said, it's afternoon here. So I'm the supervisor of resident counselors, so I supervise the staff, the direct care staff that work in our supported homes that David had mentioned. We support up to, we support up to 16 people, and I also help my colleagues that are in the supported housing team with meeting the needs of the houses, but then also the members. So sometimes I am sort of the in-between person of the members, the bridge of the members and getting their care met, and also helping connect them into the community and just being that bridge as well.
Great, Thank you, Danielle. And Dewey?
Good afternoon, everyone. Dewey Wooden, Director of Behavioral Health, Permanent Supportive Housing, and Street Outreach for Healthcare for the Homeless. We do business as Orange Blossom Family Health as well, down here in the Central Florida region, Orlando, which encompasses Orange, Seminole, and Osceola County. Those of you familiar with Disney World would know all about our area down here. We operate about 7 clinics that are FQHCs, federally qualified health centers, that offer integrated medical, behavioral health, dental, vision services to children and adults. We usually do about 30,000 unduplicated clients a year, and we're grant funded to provide services to the indigent population, homeless population, uninsured population, but we do take insurance as well, Medicare and Medicaid. I've been with them for about 15 years. We've operated homeless street outreach in the Tri-County area for about 20 years, and about 5 years ago, we decided to help lead initiative to do housing first, permanent supportive housing here in the region, and we started with PSH and received funding for that locally through private funding that then translated into jurisdictional funding about a year and a half ago. And we're housing about 200 folks in scattered site housing across the region using Housing First, which obviously the COVID-19 has impacted how we do that, and I'm sure we'll get into how that has impacted the way that we provide those direct care services, as well as how we integrate providing the health care to them, and also how it impacts our street outreach. And I can also talk about, we did partner with the City of Orlando and Orange County here to open an isolation and quarantine shelter at one of the local hotels to provide quarantine for tested folks and persons under investigation after testing of all of our local shelters and our 2 major hospital systems, and for our street outreach folks, and for not only us but our other collaborating agencies that are providing PSH in case they had clients that either tested positive or were PUI. So, and thank you, Glenn, for having us.
Yes, thank you guys all for being here with us today. Again, I recognize everybody's busy schedule in responding to this. So I think on this note, Dewey, you brought up the really great first question that we really have for the panelists. And so for the audience, I will be taking some of the questions that came in through registration, as well as making sure we monitor the chat to make sure we get those questions talked about as well. So taking off on really kind of what Dewey had started us on, and maybe I'll start at the top of the list again, Julie. If you want to share with us maybe 2 or the 3 top challenges that you're hearing from a national standpoint, being a technical assistance organization. What are you kind of hearing that are some challenges or barriers in terms of carrying out duties and care in this current environment? And really the question is it different at all from if there wasn't a pandemic? Is it just highlighting something that's already been there? So I don't know if you have any insights that you want to share with us on that.
Sure. And I will try to kind of stick to some of the higher pieces that I've kind of heard consistently. Certainly challenge number 1 is, this is not going away anytime quickly, unfortunately. And so just as a system, thinking about how we really want to change how we're working. Also the pressure points for agencies of really needing additional resources to just kind of maintain and continue providing services. I think our supportive housing providers and direct services providers probably can speak better to the things that you guys are doing to respond to that, but there are absolutely changes that agencies are needing to make, and that takes additional resources. One of the things I've also been talking a lot more about just in general is technology. And really this is a pivot point for all of us as a system to really think about access to technology for tenants and think about that differently, because clearly we're now in a space where we have to be moving in that direction and have been. And then I think the other piece is to also really recognize the stress and trauma involved for staff on the ground as well as tenants, and what that means and how to support people now and moving ahead.
Yeah, Julie, I think you did a great job kind of highlighting those big umbrella points that we've definitely been hearing too at the council, just on a national level. And telehealth and telemedicine has definitely been a big part of that conversation. So thank you for that kind of broad overlook. Just thinking more locally, David and Danielle, you guys might want to share this one a little bit. How are things, what are some challenges or barriers, particularly in Nashville, that you're encountering in terms of providing care in this new environment?
Sure. I mean, I think, as Julie pointed out, it's really highlighted the need for a different way of doing things and an opportunity to move toward telehealth and telesupport, I guess. I think, we've identified some weak points in our technical capabilities, but I think it's also highlighted a lot of the wonderful work that's already been done to lay the foundation for us to make that transition. And so for our staff early on, there were varying levels of comfort doing, telehealth and even just conference calls and trying to get everyone quickly on board with that, so then we could move toward engaging our residents in that way. And I think a good point that our IT manager made recently is that we want to provide tech for our residents, but not make them feel, uncomfortable or like they're behind if they are struggling to utilize the technology. So we have to be able to not only get that into their hands if they don't already have it, but provide the kind of support that they would need to be familiar with it and comfortable using it, so that they, don't feel kind of isolated or estranged.
Right, and that's something that I guess I never really kind of put together either, is kind of the comfort of using technology as well. So I think that's a really important point, especially that this is becoming a mainstream of care continuity. So that's wonderful. Julie, do you want to talk a little bit about some of the barriers and challenges that you're having in Orlando, or, just kind of address that? Are they different from before the pandemic versus after? And I see some other questions coming in too, Dewey, that we're going to look for you to kind of talk a little bit more about as well. But just if you have top 2 or 3 barriers or challenges.
Sure. For us, it was figuring out first, initially, what we were going to do as an agency individually, because there are other collaborating agencies, and perhaps some of the folks that are participating might speak to that too. Or understand, but some of the local other collaborating agencies, there were decisions made at their corporate level to say, hey, we're going to shut down, or we're going to keep everybody in-house and no one out. We made a decision with our case managers to work from home, and basically, in terms of our PSH program, to work from home, and which obviously presents challenges in doing wellness checks, checking on the clients, making sure their health needs are taken care of, and perhaps if they're symptomatic, what they need to do. And so that presented some challenges for us. It was a lot of telephonic interventions and wellness checks, which we do anyway, but it just kind of ramped that up. It also kind of transitioned our outreach. We have the benefit of having some outreach staff as well as our peer support staff. So those folks continued with a good amount of PPE to actually go and do home visits as needed. We continue to do move-ins, move-outs, clean-outs. Unfortunately, we had a client just pass away about a month and a half ago. So we enlist the help of our other kind of staff to kind of fill in when case managers can't get out there. And we also decided as an agency that we weren't going to, we have company vehicles that we do transports with. However, that was one thing that we did suspend, was doing transportation. But locally, regionally, our bus system here waived all fees, and they're still running those now at no cost. So it's obviously not ideal for social distancing in ways, but clients are able to use transportation if they need to get somewhere. We also have the benefit of having integrated care, so we have ARNPs and I have behavioral health, that if there is some issues in terms of folks struggling with the isolation or symptomatic possibly, we can go over there, do temperature checks. And, we also received additional CARES Act and COVID activities funding as well that allowed us to purchase tests and provide testing, so we can actually go out and test a client in their housing, and then from there make a decision about how to engage with those folks. So.
Thanks, Drew. You hit on some. Oh yes, go ahead.
I wanted to add, it kind of was a piggyback off of what Dewey said, but then also David. One of the things that Dewey had mentioned about they have integrated care. We have integration within our program, but we don't offer a lot of clinical services. So that's been a challenge for us of the integration, because we don't. Some of our integrated services, including like some of our members go to a day program, and some of them do IOP, which is intensive outpatient services, and trying to reframe how we offer those services in-house, where they usually go out of the house to do those services. That's been very challenging as well, and a lot of that has gone to phone calls, but just the formatting and trying to get we call our clients members, trying to get the members used to that new format, but then also communication with that other team has presented its own challenges too. But then additionally, the community, the other services that they receive from primary care or mental health providers in the community, like one of the other barriers we face is some of the people in the beginning didn't know how they were going to continue services, so we had appointments for some of our members canceled on the same day, or they thought that the appointment was going to be at the site, and then they found the day of that it was not. It's going to be telephonic. So those types of situations have occurred, and it's gotten a little bit easier, but we still, even as recent as like last week or the week before, we had another situation where it was like an appointment that we thought was going to be over the phone, and then they actually wanted the person to come in. So those type of things have been kind of difficult when you have some integration, but it's just trying to rethink of the best way to get the services in it for the people.
Yeah, thank you, Danielle, because that's exactly where I was gonna touch base with the Park Center panelists and kind of get that input. So, and it is similar to kind of what we've been hearing nationally too, just this variance of the ability to integrate. Definitely, has been challenging in other locations too. But it sounds like patients still have at least choice to some degree, hopefully, or as much as we can promote that, but I understand that can be difficult now. So it sounds like partnerships might be something that we can learn from. Julie, do you have any guidance on, what does partnership building look like in this environment, maybe where resources might be scarce?
Sure. So I think locally here in Chicago, we've seen it emerge in a couple of different ways. So certainly with our city's Department of Public Health, as well as our county health system, because of their critical role in leading response, brokering or pulling together some of the right pieces. Our COC also has had previous relationships and some of those foundations with healthcare partners. So for example, our Cook County Health System has someone on the board of our COC, things like that. So there have been some of those existing foundational relationships, which really then have needed to be expanded upon in a huge way. So for example, local healthcare for the homeless providers are providing a lot of the screening that's started in shelters to identify folks who are, the highest risk and also COVID negative, to help people move into a shielding hotel, moving to expand that. And I think one of the great opportunities with this is better and deeper partnerships, and particularly with our shelter providers and drop-in center providers all across the city and these healthcare providers. One of the great things that the Public Health Department also did within the last few weeks was they really assigned nurses to each shelter and really created this liaison relationship so that those healthcare providers, are a resource, can provide education and also connection to all of the shelter participants to ensure that folks who are having symptoms are getting connected appropriately, to support the shelter staff, and just having the confidence to deal with the situation at hand. If I'm working in a shelter, and when I have worked in shelters, I am not a clinician, I am not a healthcare provider, and so it is very easy to feel out of your element. So having that partnership there right on site and having that direct liaison is really, really helpful. And so these foundations will build, I think, hopefully, bigger and better relationships that are long-term overall.
Thank you. Thanks, Julie. One question that did come in that we're kind of interested in and kind of hearing a little bit more about, and is kind of, what does testing look like in residential environments? Are people going into these supportive housing units and getting testing done? Are they required to go somewhere and test? What does testing look like in supportive housing? So I don't know if, Dewey, if you want to talk first, and then we'll go back to Park Center.
Sure, I can speak a little bit to the bookends of that a little bit. We don't, we have a few people in project-based residential settings, but for the primarily most of our clients are in scattered site apartments. We didn't go out to test all of those folks. We just basically had our case managers, again, telephonically, or there were times when we were going out and doing food drops and things like that with our peer support to keep an eye on those clients. And we gave out handouts on what was going on to try to kind of decrease anxiety about everything. There was a great question I saw in the chat about those folks that suffer from SMI and perhaps some paranoid ideation, but we tried to educate them as much as possible, and then kind of doing their own symptom checks, getting out cheap thermometers, take your temperature and that type of thing, and then if they felt like they were symptomatic, we could get medical out to them to test them in their residence at their apartment, and then await the results. And then if needed, we didn't have anybody in PSH that had to go to our quarantine shelter, thankfully. And then on the other bookend of that is we just actually this week completed testing 10% of 2 of our shelters here, and our first results came back actually yesterday that they had no positives there, which is we're thankful for that. Obviously, we've seen some other areas in other cities across the nation that have add up to even a 30% infectious rate of folks in congregate shelters that were asymptomatic, which is kind of scary. But and we're waiting results on the second shelter. So what we do is we go in there with PPE, and we're doing nasal pharyngeal swabs, and then waiting on those test results with the 2 labs that we work with our clinics. A lot of times in the beginning there was a big issue for us getting enough PPE, face shields. There's a cost associated with getting fit tested for N95 masks. I'm sure some of you know that. We did accept CARES Act funding for COVID-related activities, as well as the PPP funding that we got, about $1.3 million for that. And so a lot of that is going to reimburse us for some of those costs, because in the beginning we did have to kind of scratch around to find appropriate PPE to conduct the testing for our staff. Now, so much that's not that much of an issue. Obviously, it's kind of been addressed, but we still keep an eye on that. So I hope I answered everything there. There's a lot to cover.
Yeah, no, definitely. Testing, I think we had a whole coffee chat and maybe another one coming up. So thank you for that. And, I guess I'm kind of eager to kind of also hear from David and Danielle, just because being aware of the current climate here in Nashville, just kind of wondering what it's been like for you guys. I know there's been, you know, how to work with the public health department has been, you know, difficult at times for different places nationally, but just kind of wanted to hear from you guys. What does it look like for you guys? Are you able to do testing? And just thought you guys want to share a little bit on that.
Yeah, so Danielle here. So we currently have not tested any of our members, but we have been closely monitoring symptoms. In the beginning, there was one particular, again, we call our clients members, one member that had the regular flu, and so when this, you know, it was already known about COVID, but it just was starting to, so this was like in the beginning of March. It was just becoming like a bigger issue than it had been before. And so we were closely monitoring that person, and we did end up calling our local health department. There's a, you know, they have like the call-in lines now of where you can call, and they kind of direct you of what to do next steps. And so we have had to do that now at this point for at least 2 members. But primarily what we do, we have make sure that we have posted like symptoms of COVID-19, and then also having the staff, the direct care staff that are working in the house, to discuss some of these symptoms. And some, in the beginning it was very, like, you know, a few times a week. It's not as much now, but just mainly monitoring symptoms, and then also utilizing the public health department number whenever needed. And one other way that we are, it's not in the monitoring of just the members, we also, with the staff that are coming in, because as you can imagine, a 24-hour facility, there's at least 3 staff that come in and out of the house a day to cover the 3 shifts in a day. And so we have provided surgical masks for the staff. It's a safety precaution for the members, because the staff members are coming from their own homes and wherever other places that they have been. And we also have recently obtained some guards, the plastic shield guards. We've not utilized those yet, but in the event that things take a turn for the worse, then we'll have, we're actually ordering more and more PPE weekly. We have gloves that they are wearing, and then you know, just additional masks and of that sort. And the members also have masks as well that they have made. They made like some fun masks with bandanas, but then they also can use surgical masks if need be. We're also ordering cloth masks. So just trying to be proactive and keep those PPE equipment like on regular order and, you know, disperse into the houses. But as far as testing, yes, we have not had anyone tested within our supported housing, but we've been monitoring the symptoms and then also calling in the hotlines if need be.
Mm-hmm. Great. Well, you touched on something that I did want to make sure that we covered, was kind of the staffing changes that you've had to make within your organization, and not only with, you know, case managers, but just also, you know, community health workers and peer recovery. I think a few of you have already touched on some of those, but just kind of thinking about how has the staffing changed? And I think maybe, I don't know if David wants to talk about this, and then maybe we can go to Julie and then Dewey, or Danielle, David or Danielle?
Sure, I can jump in, and I'll just mention briefly about the testing. Danielle talked about not testing anyone in our 2 supported houses, which represents those 16 individuals living in those 2 houses. But then in our larger, you know, more traditional PSH program, we have 110 residents. And without the benefit of having in-house testing, you know, we've had some struggles just getting quicker turnaround. And so pretty early on, we made the decision not to do any new move-ins and kind of put a hold on our referral process, because we don't have any way of getting results in a timely enough manner to do that in a safe way. Part of the reason for that is most of our units are 2 or 3 bedroom. The ones that turn over, the 1-bedroom units for obvious reasons, don't turn over very often. And so we've struggled with that because there are obviously people in need. That need doesn't go away just because there's a pandemic. So we wanted to move people in, especially as people are moving out of those 2- and 3-bedroom units, but we've struggled to find a way to do that safely and still prioritize the safety of the people who are already living in those units, especially with the possibility of having an asymptomatic carrier. But as far as the staffing goes, I'll say we've been very fortunate that the staff, in both residential programs have, for the most part, been safe and healthy and very willing to go in and continue to do their work as much as possible and try to, I think one thing I heard from several people is to maintain, consistency for the residents, for our members to, try to maintain some sense of normalcy in a time of uncertainty. And so we really can't say enough about how much we appreciate everyone's willingness to pitch in and really put themselves at risk to go in and work in such close contact with people. We did have one staff member who took a couple of weeks off, did not have a positive test, but was concerned about symptoms, and so we had someone stay home for a couple of weeks just as an added precaution. But besides that one person, we haven't had any major changes in our staffing, except for the way that we're delivering the services, which, moving much more, as other people have already mentioned, to telephonic intervention. So we've also really tried to make sure that we're remembering to, keep our oxygen masks close and that we're all experiencing shared and compound trauma. And many of you know right before the pandemic really became, pressing and major impact, we experienced a tornado in Nashville. And so, we were still reeling from and recovering from that, personally and with our facilities as we kind of transitioned into COVID-19 time. And so we've been really trying to, make it okay for people to take whatever time they need for themselves to make sure that they're in a, a mental and emotional state that they can provide good quality care for all of our residents. And so working remotely makes that very challenging for a lot of people who thrive off of daily interaction with their coworkers. And so we've done a lot of extra check-ins. We talk as a management team weekly, and we try to, just check on each other, make, phone calls to each other as much as possible, just to make sure everyone knows that we're all still here together in this and that we're, kind of trudging through it slowly but surely as a team, and we're not just going through it alone.
Right. No, that's great. That's awesome. And you brought up something that I do want to get to this question about some of, clients who might be experiencing paranoia or trauma. Before we jump into that, Julie, I just wanted to touch base with you and see if you had any guidance around kind of staffing, how to build staffing capacity. I know we talked about partnerships earlier to do that, but wasn't sure if there's anything from the field that you've been hearing about how to utilize community health workers or peer support coaches.
That is a great question. I don't know that I've heard anything where folks are changing specifically for community health workers or peer roles. What I've been hearing is more generally about how organizations are kind of shifting staffing and how they're providing support to people. So I've certainly heard providers talk about really thinking about, for case management staff or community health workers or peer recovery specialists, peer roles, adjusting so that, especially for a project-based building, so where there's multiple units all on the same property, where there might be limited case management on site for 3 to 4 hours a day, and it's just spread up across all of the case management team, so that people are having limited time on site and then doing the rest of their work remotely, Also implementing and communicating to tenants about how they're getting requests or how they're requesting support from the case management team when they are on site, so that people aren't coming just to the office, that there's new mechanisms for those communications. And then also implementing new ways of, if a tenant is out of food, okay, so how do we immediately respond to that? What is the protocol leaving it outside somebody's door, immediately calling them? But again, like figuring out ways to provide tenants what they need in a way that's also physically distant. For folks that are in scattered site units, I've heard a lot more examples of really refining how teams are triaging frequency of contact, so how that's being assessed and adjusted so that, if I really don't need a phone call every day, then yeah, let's not call me every day, but maybe next week things are different and I do need a call every day. So really how organizations are adjusting to really better meet tenant needs, and then also having the range of things there so that, if someone is completely out of touch, at what point do you implement a home visit? And then what safety precautions you take in those kinds of scenarios, or all kinds of things that I've been hearing across the board from supportive housing providers.
Okay. Yeah, and we just completed a learning collaborative that was on community health workers, and we were definitely hearing those roles being accessed in pharmacy places as well. So again, extending what that, capacity of the community health worker peer recovery coach actually looks like, especially still trying to continue harm reduction and MAP services for those who might be sheltering in place. So, Dewey, I want to come back to you really quickly because I don't know if you want to touch base a little bit on Barbara's question here around the contracts about that for staff capacity, but I really wanted to also, if you want to touch a little bit on that, that'd be great, but wanted to get into, residents who do have paranoia and trauma and kind of how has your organization been addressing that and responding to that?
Yeah, with those clients that again, we have a full suite of telehealth as far as medical and behavioral, but we also consider a simple phone call to be telehealth. You think it's telephonic, but it's still telehealth, and our case managers are still continuing to check in with those clients. As you guys had said, some clients need a little bit more hand-holding than others, but with our case management staff working from home, we're doing two-a-day Zoom meetings, 9 a.m. and 2 p.m., and we're checking in with them to see who they're checking in on their caseloads with and who might need help. And in those Zoom calls, we're able to kind of get out to see the client if the case managers think they're struggling or need food or assistance or things like that, or experiencing some kind of symptoms. We're able to get out there. And on those calls is also our BH provider too, one of our integrated BH providers. But any of those folks are able to go out if needed. We'll go to the client's home or apartment or where have you, and engage with them. Some of our clients are pretty savvy, and they're able to kind of negotiate the telehealth on their own. Some of them have smartphones. Some of them have computers, and they're able to do that and conduct sessions like that. But a lot of the times we'll try to go out to them, see what's going on, try to assuage any fears or any other things that are going on. Our pharmacy's still open, so if there's a need to have medications refilled or anything along those lines, if the clients can't get there to do that, we can drop off medications for them, check if their pharmacy's with us, obviously. So those are kind of some of the examples of how we're continually check in on them and then kind of provide services and bring it to their front door, so to speak, if needed. I don't know if I've been kind of responding to Barbara's questions on the chat at the same time following this. I didn't know if you wanted to talk about the shelter that we were working with here.
Sure. Yes, please. I'm sorry. I was on mute.
Yeah, as far as the contract with that, we initially worked with one of our Salvation Army local shelter here to use a basketball gym. It was still going to be congregate shelter, but have them spaced out. But the city of Orlando and the county finally, with some wrangling, came together along with our HUD lead agency, and we contracted with a local hotel chain who wished to remain anonymous while we set this up near our tourist area that was already closed, and provided 122 isolation rooms for that. These were individual rooms without facing doors and individual ACs, so they were kind of ideal for quarantining folks. And we negotiated a daily rate that would include just using the hotel room and the laundry services there as needed. They didn't provide any staff or anything. We had to provide. We agreed to provide the medical support, behavioral health support, and some limited transportation related to the outreach folks. And then the hospitals, the two large hospitals, jumped in. And if they had a positive or a PUI person that identified or self-disclosed as homeless, they would give us a call. And then if our street outreach found someone out that was symptomatic and was under investigation, or perhaps we tested and thought they needed to go in, we would provide the transportation to the shelter. And then we had the city. There were some furloughed workers from the city, from their Parks and Recs department. I was just responding on the chat. So those folks, instead of being furloughed, they were offered a chance to kind of do like a 24/7 on-site staffing of the hotel to make sure folks dropping food off to each room, gathering laundry as needed, kind of monitoring, making sure they didn't have invite any guests into the room, things like that, and didn't wander off. I did see in the chat a lot of folks in different jurisdictions and cities are struggling with people walking off and things like that. We had some folks that would walk off property. We chose not to be punitive about that either, and just kind of try to continue to educate and encourage them to stay on site if possible and continue to isolate until we needed to discharge them. So.
Thank you for that. And that leads us into kind of a question that can be difficult, I guess, in different situations, but really kind of, thinking about enforcement. We're re-traumatizing people when we force them to stay in certain, supportive housing where obviously nobody else has to experience that level of force. But, David and Danielle, I don't know if you wanted to kind of talk a little bit about kind of how you're experiencing that here in Nashville. Molly had posted what we are experiencing here, but just wanted to hear from your perspective how that's impacting your work as well.
Sure. I mean, we've done as much as we can for the people in our scattered site PSH program to support their efforts to stay at home, but we have not made any requirements for them to stay home. So we're leaving it up to them to kind of make the same safe decisions as all of us. And so what I mean by supporting them, though, we're providing, food as much as possible for people who have a difficult time getting it or who prefer not to go out at all. So we're doing porch drops, and we're providing Lyft rides or cab rides. We've really tried to shy away from our public transportation as much as possible just because of the increased risk exposure, but we're also providing guidance on, even when you're using a cab or a Lyft, how do you just, use sanitizer properly or antibacterial wipes, and just kind of some of that scrub in, scrub out procedure, just basic training to residents to make sure that they're able to do that safely. But in our supported program is really where we've seen a lot of that kind of come to a head, and I think you said it perfectly, Elena. It's really re-traumatizing, and recognizing that in the midst of this trauma and everyone's feeling a loss of control over their environment, over their lives, we've really tried to strike a balance of maintaining the safety of everyone, recognizing that there's 8 people in close proximity, and then another, 5 to 10 staff members coming in and out of those houses, some of which we don't have as much control as maybe we'd like to over how they're handling their own personal lives when they're not on the clock. But to limit the exposure, we've chosen to ask everyone to remain in the house. And so that required us to make some pretty substantial changes in just the way that we meet everyone's basic needs and try to kind of keep everyone fairly comfortable and happy. For people who are used to at least being able to go out and buy themselves a pack of cigarettes or a snack when they want to, asking everyone to stay home now for almost 2 months has been a really big challenge. And I'll let Danielle kind of address the bulk of that, but we have had some consequences of that in terms of returns to use and substance use, and then also we've had to ask some people to leave the program. So I'll kind of hand it over to Danielle if she wants to talk a little bit about that.
Yeah, so it's been very challenging, I'll admit. We've had to, put policies in place and not have those policies be rigid, be very flexible with those, and adjust to what's working, what's not working. I think that one of the biggest challenges overall has been trying to, at least in the beginning, trying to convey the message that this is not park center setting like any type of, limiting your freedom. It's a safety measure, and then it's not also, we are following recommendations from, state legislators, the government, even at a federal level. And I think that in the beginning, that was the challenge of just trying to say, hey, this is to keep you safe. And this is not a punitive approach. This is a safety approach. Once we got through that, I think obviously there were still challenges. There are still challenges now. But as David said, just trying to make sure their needs are met from cigarettes. I mean, people that smoke just in general, that's a need that they have to get met. But then also add on people experiencing mental illness and use cigarettes as a way to decrease symptoms or, deal with symptoms. They have to have that need met. So we have a plan in place for that. We have someone go on and get cigarettes every week. It's kind of like a set order for the members that smoke. But then also, like David mentioned, snacks. That's something that, it's a warrant in the grand scheme of things, but it's very necessary that people have the comforting foods and the comforting things that they typically would have. And so now we have that in place as well, and that we're getting those snacks weekly. And then also making sure their overall food need is met, which presented its own challenge of, having to change their menus in a way that we have not had to do before. I've had to, suggest certain menus based off of food we're able to get in the grocery stores, and that's even, that's a challenge for people that are already having to be told what to do, when to do it in some, forms of their life, and having their food choices kind of depend on what's in the grocery store, and trying to convey that has been a challenge in itself as well. I think I will say that our members are very resilient, and they, for the most part, have been rolling with it. Obviously, there's pushback, but it's very understandable. Like at one point, we were saying no deliveries. So other than what we are, procuring for them, whether that's food, whether that's snacks or cigarettes, no deliveries. Well, we've had to take a step back on that and, adjust that plan because, some people were ordering things from Amazon that were not necessarily, they're, not needs, but they were wants or things that are very important to them. So just setting policies, but then also being flexible enough that we are still keeping safety in the forefront, but also understanding that our people, their lives are completely changed. I mean, everybody is experiencing this at the same time, obviously, but that's a very particular group of individuals that already have limited control in their life. And so kind of giving some of that control back and hearing them out and letting them state their case of, hey, why this needs to change, and, following suit and saying, hey, that's something we can change. But there's been cases where it's not, where David mentioned having to discharge some folks from our program. Well, that's the thing, too. If it's the safety risk that we're not able to adjust with the policy we've set in place, and the members have, continued to go out, into the community with, not keeping the safety in mind, then, yeah, that's somebody that unfortunately can't stay in this program because it's a safety risk to the other members. So I think that overall it's been challenging, but we have done the best we can. I really appreciate the direct care staff that are working in the house, and then also my colleagues that I work alongside with, that trying to just help all of our members be as safe as possible, but then also understanding that, that loss of control is very triggering.
Yeah, you guys summed it up. I mean, it's really challenging, this balance of, not wanting for people to be exposed, but, the enforcement is a difficult conversation. And I don't know, Julie or Dewey, if you guys wanted to share some input as well. I know I'm realizing we have about 4 minutes left, but I wanted to give you guys an opportunity to kind of share any thoughts around the enforcement challenges or issues that you might be hearing or seeing, and how some solutions maybe you've had. And I've seen a few solutions posted in the chat from Julie as well. So,
yeah, I can share kind of from what I've heard. I think kind of the closest examples I've heard here locally, our city is definitely taking an approach of not punitive and really trying to be much more motivational. And I've just heard a lot of stories about just all kinds of creativity in trying to really get to what motivates someone, and working with people on that and whatever that looks like. And also knowing there are challenges with safety. If someone's in a hotel for quarantine or isolation, then access to, street drugs or anything else, it is an ongoing challenge.
Yeah, I would echo that. For us, as I spoke before, we weren't doing anything punitive, as Danielle was talking about. And David, for the folks in our IRC shelter, we had 24/7 folks monitoring them. We knew that they were going out to smoke, as like Danielle was saying, or go to McDonald's or whatever. We try to discourage that. And also our folks in PSH and scattered housing, again, we just try to encourage, when we were under our own stay-at-home orders here with our governor and the local county ordinances, trying to, encourage them to stay in. But, you can drive yourself and your staff nuts trying to police that. We weren't gonna try to do any of that, because it's pretty much impossible 24/7. And then as I would walk out my own front door watching my neighbors do whatever they're doing, I have no idea how I'm going to apply that to a PSH program. So we just try to educate as much as we can and kind of be as much proactive as you can, but then you got to react if there winds up with being symptoms and tests, and then bring the services to bear. So.
Yeah. It's a tough conversation. Like I said, it's definitely not unique. It's happening nationally, and it's tough. But thank you, guys. We have a minute left. I don't have time for this question, but I do want to give the panelists, there was one question that came on. If you guys or anybody that's participating might know of any grant or funding opportunities for housing, we're always happy to kind of share that information with the participants. And I think specifically as it relates to this time. So I just want to thank all of you guys so much again for your time, and I really hope everyone that has joined us had a really great conversation with us, and we appreciate you guys. Remember to look at the resources and our upcoming sessions, and thank you all for being a part of the chat today. Good luck, and everyone be well and stay safe.